And
common
things it will be in English only. Very good afternoon, everyone. We are here with one more edition of our health awareness talks. Today being World Parkinson's Day, and we will discuss something about Parkinson's disease. Parkinson's disease is a degenerative condition of the brain which affects many old people, and what happens is generally you will see people having tremor, they'll be shaking out of it. They'll be having some shaking and there will be slowness in gait. So it's a health problem of a big magnitude which is grossly under addressed. Now what with period of time, with advancement in technology and these things, more and more better things have come in for treatment options. Initially it used to be only medical treatment, but now some surgeries are available over past couple of decades which give a very good result. We at AIG, being a multi-speciality neurosciences department with a number of people specializing in each of these movement disorders. Today with me we have two of my colleagues. Dr. Suresh Babu is a senior consultant neurologist who specializes in epilepsy and functional neurosurgery, and with experience in that. With that, we have also Dr. Raghu. Dr. Raghu is a trained neurosurgeon in epilepsy and functional neurosurgery, and has an experience in treating these Parkinson's and epilepsy patients. So for today's talk, being a World Parkinson's Day, we will be having some awareness or some bringing it to light, some aspects of Parkinson's which people are not aware of or people are not knowing it. I'll start with basic things. We'll make it as simple as possible for everyone to understand. We'll ask Dr. Suresh with the first question. What is Parkinson's disease, Dr. Suresh?
Good evening, everyone. Today is the World Parkinson's Day, so we thought it is a good opportunity to create the awareness in a public about the Parkinson's disease, so that we can provide the better quality of life, and they can, in the present day, they can lead a near normal life with the present available options. Parkinson's disease is one of the most common neurodegenerative disease what we see in a outpatient department, and it affects almost around 100 people per a lakh population. And being a neurodegenerative disease, we know that gradually the severity of the disease and the functional status of the individual keep on worsening over a period of years. By diagnosing in the early state and using the appropriate interventions early, so that we can provide the almost near normal life in terms of the quality of life.
When we talk of, Dr. Suresh, when we talk of early treatment, what is the commonest age group in which it is affected, this Parkinson's disease?
Yeah, common age group is between 50 to 65 is the common age group. In very rare, in a few genetic cases, we will see early in a 20s and 30s. But in a most common scenario, in a was a 50 to 65 years is the common age group which is being affected with this.
Over period of time, is this age group slowly decreasing, or it's been over past 50 years, the age group incidence has been the same?
Incidence is same. I think maybe because of the awareness and we are seeing the more number of cases.
And this typical case of classical case of Parkinson's, what we tell, what are the major symptoms? And the symptoms unte patient can tell that, or his relatives can catch at least, so that they can seek a medical attention. What are the common symptoms they have in this?
See, common symptoms what we see was one is tremor. Tremor means the shaking of the hand. Shaking will not affect very fast. It is a slow shaking. Initially affects the fingers, then it affects the wrist. Especially it was there during the rest. When they try to do some activity, they disappear. And when they keep on doing, there may be a chance of the emergence, reappearance of the tremor. So foremost common thing is a tremor during the rest, which is of a very like a low frequency. It will be not be more than 5 to 8 heads per minute. So like along with that one, other common symptom we notice was a very slowness in the activity. Slow means they can able to mix the food, but they mix very slowly. They can able to putting the button and unbuttoning, they do slowly. And when they are walking, the movement of the hand will be swinging of the hand will be less. Because you swing less, they tend to come with the shoulder joint pain. So most of the time in our OPD, people will not come with the tremor or they say slowness of the regular activities. They come with the shoulder joint pain. So anybody more than 50 years of age who comes with the shoulder joint pain, we will look for the Parkinson's disease. So one thing is a shaking, and second one is a slowness of the activity, and the other thing is they tend to lose the balance when they are walking. But they may not fall, but they know that the sense of unsteadiness and the sense of losing the balance, especially in the plain ground where there is no reason to fall, they might lose the balance. And along with, they complain of some stiffness or the pain in the muscles, both hand, one side. So cardinal symptoms are, one is a tremor, second one is a slowness in doing the activities, and the third one is a tendency to lose the balance. Fourth one is a stiffness in the muscles, but it has to be asymmetric. They will not start both the sides of the body on the same time. They start with one side, gradually over a period of time involve the other side. And along with that one, you can see the change in voice. They have a very slow volume voice where the distant people audible, they may not audible. And third thing is, you can see their expression of the face will be very dull.
Plastic face.
Yeah, like a plastic face. They don't show any expression. So, and these are the common symptoms. For the diagnosis, we will use these symptoms for the diagnosis.
People get confused. Is it, I mean, the common person understands what is a stroke. Okay. But we definitely know that Parkinson's is not stroke which comes suddenly. It comes over a period of time and slowly increases over a period of time, you know. One small thing in this, all the symptoms which you told, does it affect the memory of a person?
Almost, at least first to 10 to 12 years, it will not affect the memory.
A very important thing what Dr. Suresh told was, it doesn't affect the memory initially actually, first 10 to 12 years. So we have to differentiate these things. So that patient may be having all other symptoms, but may not be having any memory issues in these patients. And like Parkinson's we have, like tremor and these things, that there will be so many other conditions which can produce same type of symptoms.
Yeah. See, like a common things what we see in OPD was people who take the drugs for the acidity, especially levosulfuride and the domperidone. Very like a small segment of the people, they develop the Parkinsonian like symptoms, sudden acute onset, means they affect both the sides of the body. They are very slow in walking, very slow in doing the activities with the hands, and their facial expression will be less and the speech get affected. But it is a symmetric. What earlier I told, Parkinson's disease is a asymmetric disease to start, and it comes very slowly. If it affects both the sides of the body and comes suddenly, we have to think of any toxin or the drug induced.
These are things which will appear like Parkinson's, but they are not actually Parkinson's disease. Very important thing, to side effects of drugs can also produce that thing. But any other degenerative condition like Parkinson's, we talked of degenerative conditions, any other degenerative.
Which mimics like a Parkinson's, but in terms of the response to the treatment and the long outcome will be different. We will divide Parkinson's into two varieties. One is a typical Parkinson's and the other one is a atypical Parkinson's. Typical means what I told, like asymmetricity and having the cardinal symptoms what we discussed earlier. There are two diseases which commonly mimics the Parkinson's. One is, we will call it as a multisystem atrophy Parkinson's type, and multisystem atrophy cerebellar type, and the progressive supranuclear palsy. These are the diseases which closely mimic the Parkinson's disease in the initial part of the disease. Especially in the first 1 to 2 years, it will be difficult to differentiate between the typical and the atypical Parkinsonism. So in those cases, we use the other ancillary tests to prove the what is typical and atypical.
So what Dr. Suresh brought out was a very important part. So to differentiate these small things, anyone has a family or anyone has these symptoms, it is very important to go and consult a neurologist to know these things, because some of these things can be treated early in the stages. So consulting a doctor in the early phases, or even if the minor of the symptoms starts, is very, very important in these things. And when we come to this Parkinson's specifically, is there any cause? Why? I mean, what is the etiology, or why does Parkinson's happen?
It is a neurodegenerative disease. We have some set of the diseases which are neurodegenerative, where they affect the particular cell population. They will not affect the whole brain, but they affect only the neurons which secrete the dopamine. So in Parkinson's disease, we lose the neurons which has a ability to produce the dopamine. So these dopamine producing neurons will gradually come down over a period of time. So because of this lack of dopamine, we will get all those symptoms.
So can it be genetic? It can be passed in family?
Yes, sir. There is an entity called the young onset Parkinson's disease. If the Parkinson's disease starts less than 50 years of age, we have a gamut of the genes which can produce this one. Common genes are Parkin and the pink. These are the two genes which are like among the genetic. We have a 12 known genes which can cause the Parkinsonism. These two are the common genetic conditions.
So once a patient with these tremor and these things come to you, a neurologist comes to you, how do you establish a diagnosis that this case is a case of Parkinson's disease? It is not a Parkinson's mimic or a Parkinsonism or any other degenerative condition. How do you establish a diagnosis? Means by only clinical method, or you do some additional ancillary tests to establish the diagnosis of these things?
Essentially Parkinson's disease is a clinical diagnosis. If the patient has a cardinal symptoms, and next what we will do is we will give the levodopa challenge. So once we see the patient with Parkinson's, we will give the levodopa. If there is a almost near complete resolution of the symptoms or the improvement in the symptoms, then we are certain that we are dealing with the typical Parkinsonism, and their response to treatment will be very good, and their options for the treatment will be much more in terms of the improving the quality. So for the establishing the diagnosis, one is a clinical and second one is a response to levodopa. These are the two cornerstones for establishing the diagnosis. And whatever the tests what we are going to do, they are predominantly when we are utilizing when we want to utilize the modern treatments like a DBS and the surgical method, because we need more confirmatory, we use the other tests to support our diagnosis.
The important thing is it's predominantly a clinical diagnosis. You can get a CT and MRI, but MRI and CT are not very much helpful and contributory. Yeah. They will usually eliminate, it's a method of excluding other major diseases in the brain who can mimic like Parkinson's. But what Dr. Suresh told was very important, that it's predominantly a clinical diagnosis, and it has to be dealt by a neurologist who has an experience in this and treating this. When we start with the treatment part, what is the simplest of the treatment when we can start and we can proceed further?
when we want to start the treatment, we will divide the, one is the based on the age, we will divide like a less than 50 years, more than 50 years. And we will chart out the symptoms of the patient. One, whatever I discussed, the 4 symptoms, and there are other symptoms, they are called the non-motor symptoms. Normally, patient will not tell these non-motor symptoms unless we ask. For example, they might be suffering with the constipation. They might be suffering with the bladder symptoms, especially they can't able to hold the urine. More number of times they will go in the especially night time or daytime. And the third one, there is some restlessness. Like they can't sit, they can't stand, they can't lie down longer time because of the restless leg syndrome what they have. And the other one is after eating the small quantity of the food, they feel their abdomen is full because their stomach can't relax. That is the early satiety because of the not able to relax the stomach, and they get the vomiting sensation because of this. And other one is when they are sitting and standing. Normally also there will be some amount of the blood pressure fall when you are sitting to the standing because of the gravity. But whereas in a people with the Parkinson's, that fall will be little more, and sometimes they lose the consciousness because of the drop in BP. And these are the symptoms we will note down. Is there any sleeping disturbance? Once we why it is important is when we are about to start the treatment, we need to know these things. Reason is I am giving a drug. If the stomach is not emptying, that action you will not see because it is not going down and it will not absorb. And the second thing, when we are managing, it has to be a holistic. Means not only the motor symptoms, you need to concentrate on non-motor symptoms to improve the quality of life. In young patient, when I am starting the treatment, we have 2 categories. One is a dopa agonistic drugs and the second one is a levodopa. Dopa agonistic drugs commonly we will use 2. One is a pramipexole and second one is a ropinirole. And the second drug what we will use is a MAO inhibitors, which they are like antioxidants. They delay the progression of the disease. So any young patient when I am starting, we will use the drugs which will delay the progression of the disease, and we will use the dopa agonists.
So one of this, what you are talking of is, when you talk of Parkinson's disease treatment, one is to take care of the tremor and bradykinesia, and the second part of the treatment is to take care of the progression of the disease. Many of the technical medications, what Dr. Suresh tells, it may not be easy to understand for many of us, but important thing is the first medical management is the most important thing, and not only treating the Parkinson's only, treating the symptoms which are all associated with Parkinson's is also very important. So these are the only 2 drugs you use, or you as?
Yeah, predominantly like a levodopa, and to prolong the action of the levodopa, we have other drugs like a entacapone and the carbidopa. These are actually to potentiate the syndopa effect. And this is the predominant cornerstone of the treatment is the levodopa. Somebody responsive to the syndopa is where we can look for the other options.
So the medical management has started in a classical Parkinson's patients. When do you feel that this patient is crossed the threshold of medical management, some better things or some other thing has to be offered to him? What is that a line, or what is a threshold when you wait till?
Yeah.
Or is it that any case of Parkinson's, we should always suggest them an early other option, treatment option?
Yeah. In my practice is the moment I diagnose the Parkinson's disease, I will tell them that you have to mentally prepare for the surgery, because nobody will accept immediately after the 5 years into the disease. If I say that go to surgery, everybody will deny. And the second thing is the cost. So if we are well prepared for to handle the Parkinson's, we know that we are going to live with this disease and we can give the better quality of life and near normal life. So I prepare them from the day 1 I am starting the treatment. I will make sure that my patients will get the insurance. because like if they don't have insurance, I will ask them to take the insurance. And from that day, if we are following, it is easy to for the transition from the medical management to the newer modalities of the treatment over a period of time. Every visit they will come, I will emphasize for the like a surgical program, because patient will, one is, I know that this patient definitely requires a surgery because this is based on the natural history of the disease. Everybody on the 6th or the 7th year likely to requiring a surgery.
All patients who go on medical treatment also, down the line, it keeps on degenerating. So as we told, there is no medicine to stop the degeneration. Like aging, we cannot stop. So degeneration also we cannot stop in these conditions. So as you go down the line, the requirement of medication keeps on increasing, and they become sometimes down the line become non-responsive in spite of multiple drugs. And as Dr. Suresh tells, and very rightly, that he sensitizes the patients from day one about that down the line you may require surgery, and it gives patient to understand the disease, because now so much information flows on the net and everything, so people understand the disease and the modalities available. Now medically speaking also, Dr. Suresh, what is the threshold that yes, I will not go beyond this with medical treatment? When do you tell that?
Normally by 5 years or 6 years, we can see that our drug, initially when we give the drug, it works almost for 6 to 7 hours. Gradually, the same drug will not give that effect. It will give only 2 hours or 3 hours. And the second thing is, as the neurons are degenerating, you will see there is a, normally what happens when I give the drug will go inside the neurons, it releases whenever it is required. When your number of neurons are reducing, your blood levels of the drug increases, there is nobody to take up that drug. So during that time you will see the dyskinesia. Dyskinesia means more movements in the body. It is like a chorea-like movements involving the whole body. They will be moving this side, that side, and perioral movements. This is because number of neurons are reduced. Whenever I give levodopa, suddenly it increases, suddenly it comes down. So during that peak period, we will see that like a lot of abnormal movements in the body, and the effect of the drug will be very shortened. So this is the time we need to go for the.
So indirect, what very important point he told was, degeneration happens. So more and more neurons are getting degenerated. Less number of neurons are available to take the drug, and when they take the drug, they get more excited. So those abnormal movements are formed. So that is a point when he feels that the the body will not take any more medical treatment. He has to go in for surgery. So I will come to Dr. Raghu now. So
yes. Good evening.
Is surgery an option? I mean, obviously now more and more surgeries are happening in Parkinson's disease. So if the fundamental question, I'll put it to both of them, Dr. Suresh and Dr. Raghu then. First I'll take it to Suresh. How do you tell them that yes, the surgery is an option now?
Like once I establish the diagnosis, and if they show the consistent response to Syndopa, and once they start developing the abnormal movements and the less duration of the drug action is less, and that is the, I feel, ideal time to sensitize them and to send to the surgery. Only one thing we need to do is we do two things. One is does his memory got affected? Means when we are putting a device or doing something, does the person can able to handle it? And the second thing is any psychiatric issues. These are the two conditions where normally we will not push for the surgery.
So Dr. Raghu,
yeah.
Fundamentally, many people are aware that there is a surgical option available. They commonly call it DBS.
Yes.
So I'll ask Raghu, enlighten us, what is DBS? What is the meaning of DBS?
Okay. So as Dr. Suresh emphasized about like what are the classical symptoms of Parkinson's disease, and like what is the medical management, what are the drawbacks, and what is the limitations of the medications. The next comes the DBS, which is called as a Dbs stimulation. So in which we place an electrode inside the brain where there is a problem, which is called like basal ganglia. Dr. Suresh has emphasized on it. So we place a basal ganglia, the electrode in the basal ganglia, and we try to provide some current, so which will inhibit the hyper functioning of the abnormal part of the brain, which is undergoing the neurodegeneration.
So, and who are the ideal candidates? If we talk of a deep brain stimulation, what he was talking of is just like you put pacemaker. Many people are understanding what is a pacemaker. Whenever the heartbeat becomes abnormally slow, which doesn't respond to medication, the doctors advise you a pacemaker. So a device is implanted with the battery, the wire is connected to the heart, and it gives a continuous stimulation. So DBS is something for the brain actually. So if we talk of deep brain stimulation, who are the ideal candidates for DBS?
Yes. For the ideal candidacy to select for a DBS, the proper evaluation of the patient is very important. So as Dr. Suresh said, like there are some cases in which there are secondary causes of Parkinsonism or the Parkinson's mimics, like PSP, MSA, etc. So in which the surgical results are not so good. So the patients who have the classical features of like slowness, stiffness, and the tremors, along with that good response to levodopa and levodopa induced dyskinesias, which is the increased movements. These patients are the ideal candidates for the DBS. Because
very important part, Raghu, sorry to interrupt you. The dyskinesia is what Dr. Suresh was mentioning about, that the neurons have degenerated, and when you give a classical dose of medication, they produces abnormal movements. So that they are the candidates. So we have a multidisciplinary team in our hospital, wherein a neurologist, a neurosurgeon, a psychiatrist, they all sit together and discuss about a case of Parkinson's, and this information is shared among all, the clinical evaluation is done, and that's the point, the decision is taken that Dr. Suresh and Dr. Raghu decide that yes, these patients are the one who will require a surgery. So out of, Dr. Raghu, if you see 100 Parkinson's patients, what is that, I mean roughly what is the percentage of patients who will get benefit from DBS?
So in a case of ideal candidate, that idiopathic Parkinson's disease, without any red flag signs that we have discussed, not because of the other causes, it is because of exclusive degenerative disease because of this thing, almost every patient gets benefited from DBS.
That's beautiful. If the patient has been worked out and evaluated properly.
Yes.
And most of the patients, if Raghu tells, it's Dr. Raghu tells that it's most of the patients, so it's must be it's a very good number, and it's very, very encouraging to know people to know about it, that there's a surgical option available which gives a very good cure to this problem. So when we talk of surgery, how challenging is the surgery? Is it a very, very complicated surgery? Does it have a lot of side effects? When an apprehension comes in the mind that surgery in the brain, many people avoid it, but for everyone's understanding, it's one of the very simple surgery where it's not a very big invasive surgery. Dr. Raghu will tell 2 lines about the surgical part so that we don't have to worry too much about the surgical aspect.
So the success of DBS surgery lies in the proper evaluation. It's a team-based approach where we select a right candidate for the surgery. That's the first thing. So nowadays the imaging has improved a lot, where the target of our electrode placement we can accurately localize with the newer advanced modalities, and also intraoperative physiological data, etc. So we can accurately localize the placement of electrode. We can even see the blood vessels, which can minimize the bleeding risk at everything. So it's almost like when properly planned, the surgery is almost of no risk. It's like almost 0.2% of bleeding chances. Like in 1,000 patients, 2 patients may get minor hemorrhages. Even in that, like less than 0.1% will have the major bleeding. Coming to the electrode, the size of the electrode, it's roughly like less than the size of a diameter of a refill, pen refill. So we'll make a small hole in the skull, which is like a size of a button. this can be done without even anesthesia. We can just give a local anesthesia and we can place that electrode into the brain under image guidance, in which like we can know that where our electrode is going exactly. And at the same time, once we place that electrode, and we can also see like whether the electrode is placed as per our plan, or are we deviating from this thing. So it is very safe surgery in the modern era. They don't have to worry about the surgical complications, and the accuracy will also be very good along with the results.
So it's a very precise surgery, to be specific, and to make the surgery more precise in AIG we use most of the centers, they use something called as stereotaxy, neuronavigation, and confirmation with an MRI, and patient is conscious during the surgery. Patient knows what is happening, but he will not feel the pain or anything, because the exact targeted point which is calculated to place the electrode. So Dr. Suresh and Raghu both will be in the theater, and they will be continuously evaluating that when you stimulate that electrode, how the response is there, and then they find the best point where the patient has the best response, and it is locked at that point. And after that, they are connected to the
this battery. Like there's a IPG battery, like what we use in a cardiac pacemaker.
So there is a battery which is placed outside and below the skin, not outside. And nowadays with advancement in technology, rechargeable battery,
yes,
long life batteries are available.
Even the size of the batteries are very small.
Very
They are
small.
not appearing.
So what is an average life of average life of the device?
So it depends on two things. One is the rechargeable battery and the non-rechargeable battery. The other is how much current the patient needs. That's so roughly speaking, it's like 5 to 7. And if like patient we use the less current, it may go up to like 7 to 8 years.
So this is a fairly straightforward, precise and simple surgery which can be done at the place, but it requires a certain set of training and expertise. And Raghu and Suresh being both specialized and doing this. Dr. Suresh, common question asked in everyone's mind is, can Parkinson's be prevented?
No, sir, it is a neurodegenerative disease. No, not a specific proven risk factors. Age is a risk factor, it is a non-modifiable.
So is there any model to predict that yes, these are the set of patients who are going to develop Parkinson's, and these are set of patients are more prone that they will develop a Parkinson's early in life?
No, sir, except the strong family history.
Okay.
Yes.
Like we can't predict, sir.
So, so we gave you a brief outline of what is Parkinson's disease on this World Parkinson's Day, where more and more patients are getting affected, they are getting diagnosed and they are getting treated. For everyone to understand what the disease is, any last thoughts on this, Dr. Raghu, about the surgical?
Yes. So it's a basically age-related disease. Most of the times, what we think is like as the people grow older, we think that my father is slow. It is just because of age, not because of anything else. This is a misconception. So until it is brought to a expert neurologist, he may diagnosed with Parkinson's disease, and where the treatment will almost give him normal life. He can carry his independent life. He can go for a walk. He can enjoy with his friends. So this increases the quality of life, whatever he has.
Quality
So
of
rather
life
than
is
suffering. Yes.
Quality of life is the most important criteria which we look at in any disease, treating any disease. So is in Parkinson's actually. You don't want to make the patient bedridden, dependent on these things. Most of these patients who undergo treatment, medical followed by a surgical like Dbs, deep brain stimulation, lead a normal quality of life. Dr. Suresh, any last words
Yes,
for
sir.
our?
Any slowness to be brought to the neurologist?
Point. Any slowness which is there, let us not neglect it and take the neurologist opinion as early as possible, so that it can be diagnosed and established what it is and the treatment can be followed. With these words, we thank you one and all, and with especially thank Dr. Suresh and Dr. Raghu. They are part of our, we have a small multi-specialized Institute of Neurosciences are here at AIG, and each of these specialized works are carried out, and they are part of the team on this who take care of the functional and epilepsy treatments. So thank you very much. Meet you again later date with another health talk. Thank you very much.
Thank you.
Thank you.
Thank you.